All right. Okay. So welcome everyone to our topic heart failure. Today we are focusing on few things only. We are not going to talk about full heart failure. We are just focusing a little bit on heart failure with reduced ejection fraction. Okay. And we are going to talk about some selective therapies in heart failure. Good. So everyone knows me, right? I'm still a clinical instructor with University of British Columbia. Currently, I'm working in Ontario. I have a practice in rural Ontario, in Brighton and Trenton, and I also have a practice over here in Pickering. So multitude of practices. All right, let's begin something simple. So we have types of heart failure, right? So heart failure, we have three types. Heart failure with reduced ejection fraction, where ejection fraction is less than 40%. Heart failure with mid-range ejection fraction, so it's 41 to 49%, and heart failure with preserved ejection fraction, where ejection fraction is more than 50%. Previously, all these definitions were not there. They were simple things like congestive cardiac failure, and then that was it. As time evolved, now we have learned few things, right? That now we have learned a little bit around the pathology of heart failure, right? So if this is the heart, right? Let's say interventricular septum, and this is your atria. Now we have learned few more things. So what we have learned is that there is a type of heart failure where the heart is not pumping well. Okay, where the heart is not pumping well. That is your heart failure with reduced ejection fraction. Where it's not pumping well, it doesn't have the power. Okay, it doesn't have the power. Yes, there's compensated, decompensated, absolutely, where there's no power to pump properly because heart is like a motor, correct? And we have also understood that there is a type of heart failure in which the heart is just stiff, right? It's just stiff. So it is ejecting okay, but there's not enough it is ejecting. It is just stiffness, right? So that is your heart failure with preserved ejection fraction. And then there is a heart failure with mixed, both types of things in it. So there is heart failure with mid-range ejection fraction. Now, majority of the drugs that we know have evidence for what kind of heart failure. Type 1 is this one, 2 is this one, 3 is this one. Most of the medications that we have that we know of, they have evidence for what type of heart failure. Very good, very good. Heart failure with reduced ejection fraction, right? Heart failure with reduced ejection fraction. Okay, so that is something which we have the highest evidence for medications for. Heart failure with mid-range ejection fraction and heart failure with preserved ejection fraction, we don't know too much. We are working because there are trials and stuff going on, right? There are trials and stuff going on, and we are trying to figure out a little bit more around what are the medications that provide us with good benefit. Okay, moving on. There are four pillars. So please remember this, everyone. There are four pillars, core standard therapies, four pillars of heart failure. One is an ARNI. So what is an ARNI? Have you guys heard of Entresto, sacubitril valsartan? Yes, no, yes, no, yes, no, in the chat box. Okay, good. So most of you guys have heard of Entresto or sacubitril valsartan, right? And that is now preferred over just starting someone on an ACE inhibitor or an ARB. Okay, it is preferred over starting someone on just an ACE inhibitor or ARB. Now, what is the mechanism of action for valsartan? Most of you guys know that, right? What is the mechanism of action of sacubitril? A lot of you guys don't know that. So what's the homework for today? You go and you read like what are these neprilysin inhibitors, what do they do and stuff like that. You read it once and done. You don't need to keep reading it because that's not something that will be asked in QE1 is not going to ask like, okay, tell me the mechanism of action of sacubitril. No, right? The, I mean, I shouldn't say they won't ask, but I'll say the chances of them asking are very, very low because they are more around application of a concept, right? They're more about application of a concept than anything else. Correct? Number two is our age-old beta blockers, right? The oldest medications that we know of, one of the oldest medications are beta blockers. Carvedilol, bisoprolol, metoprolol, etc. Two types of beta blockers that we know of. One is cardioselective and another one is non-cardio selective. Why do we need cardio selective? Does anyone know? Why do we need cardio selective? Please type in the chat box. What's the reason? Why do we need it? What is the need for cardio selective? To reduce side effects. Okay, good. Any other reasons? Good. To reduce the side effects? Absolutely. Anything else? So what you guys have to think of, like I said, very good, Dr. Aisha, absolutely. So for QE1, NACOSCI, CARMS interviews, any interviews in Canada, the biggest thing that you have to focus on is breadth. Okay, for a topic, how broad it is important. Okay, then how deep it is or depth. Breadth is very important in QE1 and NACOSCI exams. What do I mean by that? So can we have people who have heart failure but they have asthma and or COPD? Can we have people like that? Yes, no, yes, no, yes, no. Yes, right? Yes, absolutely. We can have people like that. Okay. So, in those people, what do? We can't give non-selective beta blockers. We have to give selective, right? Because then it helps them, right? Then it helps them. Correct? So, we have to think broad that in what cases or why will we need this? Because we have people like this who are having these types of issues. Good. All right. Then you have mineralocorticoid receptor based medications such as spironolactone, eplerenone, and so forth. Right? These are your MRAs. That's number three. Okay. Number four, this is a relatively newer addition in last few years. All right. This was not there before. And that is your SGLT2 inhibitors. These are your dapagliflozin and empagliflozin, your Jardians and things like that, right? What are these medications primarily used for, everybody? What are these medications primarily used for? Very good. These medications are primarily used for diabetes. Absolutely, they're primarily used for diabetes. But you know what? The side effect profile of these drugs is amazing. What is one of the biggest side effect of SGLT2 inhibitors? No, I mean, I don't mean like that. I don't mean like that. The side effects, which are now considered therapeutic effects, are that they help with the function of your heart, right? So congestive heart failure, diabetes, you use it. Jardians and these medications are very, very good. They are renal protective. What else? They're also cardioprotective, right? They're also cardioprotective. These are the newer things that are coming out. They came out in last few years and now we are trying to incorporate in everything, right? Big problem with them is the cost, right? Big problem with them is the cost, which will eventually come down, right? Like it will eventually come down, but big problem is the cost of these medications. Especially the Entresto is quite expensive. Okay. Now, GDMT is a short form that I'll use in a lot of questions after this, is your typically guideline directed medical therapy, right? GDMT, guideline directed medical therapy. So what should be your ideal goal? So I have written over here, initiate and titrate all four therapies within 3 to 6 months, right? But you also have to see how is someone presenting in terms of their heart failure clinically, right? In terms of their heart failure clinically. Now, let's say if someone has heart failure with reduced ejection fraction, right? But it's on the borderline and they're having no symptoms at all. They're completely healthy, okay? Then what do? Do you initiate all four and then say, okay, bye bye? No, you don't. You start low, go slow. Start low, go slow. You start with a medication. Let's say they are having pedal edema or something like that. Maybe consider spironolactone, right? If they are having metabolic syndrome type things, consider SGLT2 inhibitors like dapagliflozin or empagliflozin, right? What else? If they are having difficulty with their heart rate, consider maybe beta blocker or something to help them out with that, right? What else? Last but not least addition is your ARNI. Now, let's say they're not having enough money for ARNI or something. Can you still consider ACE inhibitors? Absolutely, you can consider ACE inhibitors, right? But ARNIs are better. However, you can still consider ACE inhibitors as well. So all of these, which medication to choose, how to start them is very nuanced, is very patient specific, is very patient specific. It is as if someone comes in and says, you have a 65-year-old male whose hemoglobin A1C is 8. What medication will you start? Right? No, no, that's not a good question, you know. I mean, sure, you can say I'll start with metformin. That's fine. That's fine, right? However, you have a patient, right, who same thing, 65-year-old comes with hemoglobin A1C of 8, right? Comes with hemoglobin A1C of 8, but they have some genetic disorder about oxidation or something. Maybe metformin might not be a great idea for them, right? You have, let's say, someone with hemoglobin A1C of 8, but they have a very short gut syndrome or something, right? Then your Ozempic or semaglutide might not be a great first choice, right? Might not be a great first choice. There might be other medications you could consider as well, right? Nowadays, that is changing again, everybody. After probably a year or so, this might change too. But these are some of the things that you have to look at when answering questions in terms of what is the patient doing? How is the patient right in front of me? Okay. All right, let's start with some selective use therapies, and this is the primary purpose of this lecture, and that's why I have chosen it. So, you have a 68-year-old man with heart failure and reduced ejection fraction. He is on all four medications, our GDMT, guideline directed medical therapy, right? So, this person is on guideline directed medical therapy, GDMT. He is on your Entresto or sacubitril valsartan. He's on carvedilol. He's on spironolactone. He's on dapagliflozin. You did the right thing and you're feeling really, really good about yourself. He is still short of breath, still fatigued, still he's not living his life. He comes to your office and says, Doctor, I'm still short of breath, doctor. I'm still tired and I don't feel like I have a good quality of life. Okay. Do we say like, you're on four medications, okay, bye, get out of here. You're on optimized therapy. You don't need anything else. Do we say that? Yes, no, yes, no. No, right? No. Now, what do we do? What do we do? So, we need more information, right? We need more information. And what more information do we need for QE1? We are going to talk about it in the next few slides. So, number one medication is your ivabradine, right? Ivabradine. How ivabradine works? That is your homework again. You guys will take a look at the mechanism of action. So, you take a look at the patient's vitals. Blood pressure is completely normal. He is in sinus rhythm, but the heart rate is still high. Okay. Heart rate stays around 78, 86. Heart rate stays around this range, right? And this is a number that matters. Like, why is this going on? Despite doing everything right, is the heart still working too hard? That's what QE1 is asking you, right? What do you guys think? Do you think the heart is still working too hard? Right? High heart rate? Yes, no, yes, no? It is. It is working hard. So what do you do then? What do you do? You give them a medication which helps them in reducing or slowing down the heart, right? Again, everyone, heart is a pump. So you give them a medication in slowing down the heart. What is that? That's your ivabradine. Okay, this medication is your ivabradine. So remember this person with heart failure with reduced ejection fraction or HFrEF, heart failure with reduced ejection fraction, number one. Number two, this person is on best possible therapies. So all the four guideline directed medical therapies, GDMT, right? But their heart rate is staying high. Their heart rate is staying high. It's not coming down. It's not coming down. What are we going to consider? We are going to consider evaporating. We are going to consider evaporating. Okay. Moving on, let's change the scenario. So this is another medication, vericiguat or vericiguat, however you guys want to say it. Nowadays, I'll say this, the medications have like very hard names, they're very hard names. Like all the monoclonal antibodies, oh my God, I feel like it's another language, you know. It's another language. Yes, Dr. Aisha, very good. If the patient has atrial fibrillation, then that's your slide number four. That's the fourth medication that we are going to talk about. Okay? So now imagine same patient, same medication, everything is same. Okay? Same patient, same medication, everything is the same. All right? But this time you recognize his name before himself. You're like, oh, wasn't this patient admitted? Now, this patient has been having multiple hospitalizations, right? This patient has been having multiple hospitalizations despite best treatment. Best treatment. Now, in Canada, okay, in Canada, our healthcare system, what does our healthcare system want in Canada? What does a healthcare system want in Canada? Anyone can answer that? What does a healthcare system want? Oh my God, Dr. Karen Dunn, you should start practicing. Okay. So in Canada, the healthcare system wants one and only one thing, and that is keep the people out of hospitals. Keep the people out of hospitals. It costs the government about $30 or $40 to see a family physician. Okay. For a patient to see a family physician, it costs the government around $30 or $40. Same patient, when they go to the emergency room, it can range anywhere from $1,000 to $5,000. Okay. From $1,000 to $5,000. So, and when that same patient is hospitalized, it can be anywhere from whatever $2,000 to $10,000 a day if they're ICU or anything like that, right? So the biggest priority of the healthcare system is to make sure that the people are healthy and well managed and they stay out of the hospital. So rehospitalization prevention is a very, very big priority of our healthcare system. So if you guys remember the guidelines for asthma and COPD, a long time ago, we used to start people just on Ventolin. We used to start people just on salbutamol inhaler. Okay. Anytime somebody came with COPD or asthma, first line of treatment was salbutamol only. Now we have realized that if we use salbutamol only, there are patients who keep going to the hospital or keep getting hospitalized often. So, newer guidelines for these conditions, they are not salbutamol only. For asthma, we give them a steroid like Symbicort, okay, like Symbicort, which has budesonide and formoterol, okay. So for asthma, we do that. And for COPD as well, they say you can give a LABA or a LAMA. What it means is you can give a long-acting bronchodilator or long-acting antimuscarinic agent like tiotropium or Spiriva. So now what we are doing is even if the person is having mild asthma, mild COPD, we still start treating them. Why? Because evidence has shown that it prevents hospitalization. So again, coming back to the priority, prevention of hospitalization. So person with Heart, HFrEF, heart failure with reduced ejection fraction, very well managed on guideline-directed medical therapy, still keeps coming back again and again for hospitalization. Look at, consider vericiguat or vericiguat, whatever you feel comfortable remembering it, pronouncing it, but look at this medication. Good? Moving on. Now, the patient says, I am still exhausted, or the patient is in atrial fibrillation. This was the question of one of our other doctor, Dr. Aisha. What can we consider? We can consider digoxin as well. We can consider digoxin as well. Okay. Please remember, digoxin or digoxin, however you pronounce it, is more about controlling symptoms, right? More about controlling symptoms when other options are limited, right? More about controlling symptoms when other options are limited. It's not a medication that you'll give lifelong to somebody and is amazing evidence and all of that. No, no. It is primarily, it serves a purpose and that's about it. It serves a purpose and that's about it. It helps in giving good quality of life. It helps in giving good quality of life. That's what this medication is for. So again, excessive fatigue versus a person in atrial fibrillation, you give this, consider digoxin or digoxin. And last medication, selective therapy for heart failure with reduced ejection fraction, is your hydralazine and isosorbide dinitrate combination. Hydralazine and isosorbide dinitrate combination. This is one of the favorites for USMLE exams. Okay. This is one of the favorites for USMLE exams, but QE1 also likes it. QE1 also likes it. So let's say the patient develops angioedema. Now, angioedema is the side effect of what medication out of the four? Angioedema is the side effect of what? Very good, ACE inhibitors, right? ACE inhibitors. So let's say this patient develops angioedema. Can you give ACE inhibitors in a person whose kidney function is falling down? Can you give ACE inhibitors in a person whose kidney function is consistently falling down? Yes, no, yes, no. People are like, oh my God, I don't know. Can you give ACE inhibitors in a person whose kidney function is falling down? Okay, yes, no, yes, no. The answer, no, no, no. Anytime someone's kidney function is fragile, it keeps falling down, we hold the ACE inhibitor, right? We hold the ACE inhibitor. We don't give them ACE inhibitors. If they have stable renal function, if they have stable chronic kidney disease, yes, ACE inhibitors are great, right? We consider ACE inhibitors in those people. But in a person in whom the function is not stable, it is variable, it is worsening, it is going down, you hold the ACE inhibitors. You can't give ACE inhibitors. Good? All right. In terms of electrolytes, can ACE inhibitors cause hyperkalemia? Can ACE inhibitors cause hyperkalemia? Yes, no, yes, no? Yes. Okay. Amazing. So ACE inhibitors can cause it, right? So in those cases, many times ACE inhibitors are not an option. Okay. ACE inhibitors are not an option. Or now this is your personalized medicine. This is your patient-centered medicine. If the patient is of African descent, right? If the patient is of African descent, right? African American, African Canadian, Black patient, whatever is the preferred politically correct language, right? So it depends on the patient's ancestry, right? So if the patient is of African descent, then the best medication to consider, that best medication to consider is your hydralazine and isosorbide dinitrate, is your hydralazine and isosorbide dinitrate. This is the fourth medication, selective therapy for HFrEF heart failure with reduced ejection fraction. So far, everything clear, everyone? Yes, no, yes, no? Okay, amazing, amazing. Let's move on. Okay, this is this is just short functions. Yes, Dr. Sila, ACE inhibitors are renoprotective, absolutely, but you cannot give them in a person in whom the renal function is declining. So somebody whose GFR, let's say, was 58 2 weeks ago and has fallen down to 45 now, and then after 1 week it goes down to 32 and so forth. You can't give ACE inhibitors in them. You have to hold it. They are harmful, they are not helpful at the time. Once the kidney function is stable, you can consider restarting them. What's the reason for it? It is more pathology. You find it out, and if you have time, paste it in our Telegram group so everyone knows. Okay, that's how I do the paid classes. We do this, we find it, we paste it in the group, everyone finds it and learns from it. Good. All right. So this is just a snapshot of the selective use therapies. 4 questions for QE1, very easily asked. Please remember it, don't forget. Okay, now initiation strategy and consideration. So this was a question asked before that do we have to start somebody on ARNIs and all these medications? This was a question asked before. So there is, like I said, there is no fixed sequence of therapy initiation, right? It's not like, oh yeah, I have to start with Entresto first. No, you have to tailor to the patient, like what I had said, right? It depends on how the person is in front of you. Let's say somebody comes in with, for example, diabetes and heart failure. Okay, then starting Jardians might be a good idea, right? Starting Jardians might be a good idea. Let's say someone comes in and they struggle with pedal edema and heart failure. Okay, then starting spironolactone or a diuretic might be a good idea, right? So these medications help depending on how the patient is presenting. Good. What else? You can also consider parallel initiation of therapies, meaning you can start somebody on beta blocker and let's say spironolactone or eplerenone at the same time, right? So consider parallel initiation of it as well. What else? You continue with the same treatment during any illnesses and reassess and resume pause therapies before discharge. So if the patient is admitted, right? Let's say you stopped someone's ACE inhibitors or you stopped someone's beta blocker or something like that. That's fine. You can start after discharge. Because let me ask you this. So if somebody is admitted because their ejection fraction is going down, right? If someone is in heart failure, admitted in the hospital, and their ejection fraction is consistently going down, would you instantly put them on a beta blocker? Would you instantly put them on a beta blocker? Yes, no, yes, no? No, right? No. Why? Why? Because they reduce the contractility, they are negatively inotropic, and a lot of things, right? So you again, you have to see that very good. It can cause bradycardia and a lot of problems, right? So you have to see how the patient is presenting. Once they are stable enough, you start them on and send them home. Exactly same concept applies for a lot of medications. Good. Then monitoring and education. So this is also a QE1 question they can ask you, right? Person discharged from the hospital comes to you in the office. Which one of the following will you consider monitoring? So they'll have number one, respiratory rate, number two, SpO2, number three, potassium, right? Like that. Choose which one. So answer potassium. So renal function important, potassium important, blood pressure important, and so forth. You can use target or maximally tolerated doses, right? So for example, let's pick any medication. So let's say, for example, you pick metoprolol, okay? And for example, the guideline says you need to put the patient on 50 mg twice daily, okay? Now, when you start someone on 50 mg twice daily, the patient comes to you and says, Doctor, I've been having severe fatigue. I can't do my work, can't do my function, and so forth. Okay. Then you do 25 mg twice daily. Patient says, Yes, doctor. Now my energy levels have improved. Really good. Still, can I go off it? Do I need to do something? Then you say, Okay, you know what? I'll put you on 12.5 mg twice daily. You know why? Because you don't want the patient to go off the medication. So you give them the medication on a maximally tolerated doses. Ideally, you need to put them on a guideline indicated dose. But if their life is hell, they're not going to take it, right? So that's the reason why you put them on a maximally tolerated dose. What else? You need to educate the patient on few things like sick day protocols. So, for example, they develop gastroenteritis, diarrhea, etc. Then you can say might as well hold the diuretic or something, right? Medication adherence, very important, and symptom monitoring like weights and stuff like that, they can do. Okay, device therapy consideration. So I would say not one of the high yield topics, but there are devices like your implantable cardiac defibrillator, or you have CRT, which is your resynchronization therapy, which can sometimes act as ventricular resynchronization, pacemakers, etc. There are these devices that you can consider, but only after making sure that the medical management is good. Again, everyone, I don't think devices is something that QE1 will focus as much for your exam, right? But medical management, please know it, right? Prevention of hospitalization, please know it. Atrial fibrillation and CHF, please know it, right? That is important. Good. Let's do some MCQs and take it from there.